So I'm going to now move on to our next topic. Again, my disclosures. Our objectives is to integrate new information on MS immunopathology into our treatment decisions regarding disease modification and monitoring outcomes. And this is the summary. We're going to review possible directions for immunotherapy, new targets and pathways, some of which you've heard about already. And I'm going to talk about some of the development in biomarkers for these, as well as clinical endpoints for therapeutic trials. All right, disease markers in MS. What can we measure? Well, we can measure alterations in the immune system. We may be able to measure axonal and neuronal injury. We can look for blood-brain barrier disruption. We can potentially look at demyelination. We can also think about oxidative stress and excitotoxicity, gliosis, and perhaps even conceive of biomarkers for remyelination and repair. And when we think about biomarkers, we have to think about where they can be helpful. They can be helpful in terms of stratifying risk, staging the disease. They may be predictive of efficacy. They could potentially even be used to individualize therapy. And they may also have effects or benefits in the setting of side effects, long-term as well as short-term safety. Now, I'm not going to go through this in tremendous detail. These slides are just indicating that there are quite a few immune system biomarkers that have been identified that involve things like cytokines and chemokines, complement, adhesion molecules, biomarkers that reflect antigen presentation, cell cycle progression and apoptosis, a whole variety of antibodies, and biomarkers that are reflective of immune-mediated neuroprotection. And each of these things can be measured in a variety of conditions, either within the peripheral blood or within cerebral spinal fluid. Now, I'm going to spend just a little bit of time going through some of the cytokine biomarkers because I think it is important to conceive of how this process works. You start off with the naive T cell, and in the setting of pro-inflammatory cytokines, you can differentiate that naive T cell into a Th1 cell that then is pro-inflammatory. So these Th1 cells produce the pro-inflammatory cytokines interferon gamma and tumor necrosis factor alpha. Those are pro-inflammatory cytokines. And we think that these cells have a crucial role in MS by initiating inflammatory cascades. Now, the Th0 cell can differentiate also into Th2 cell, and this makes anti-inflammatory cytokines like IL-4, IL-10, and these may be involved in regulation of anti-inflammatory effects as well as allergy, as well as B-cell effects. Now, there's a new class of T cells which are called Th17 cells, and these are highly inflammatory cells. They are induced by use of IL-6 and TGF-beta as well as IL-23. And what was very recently identified in a series of studies done that were just recently published in Nature was that salt concentration actually influences the development of these highly pro-inflammatory Th17 cells. So these cells can be stimulated by IL-6 and TGF-beta in vitro, but when you increase the salt concentration by about 40 millimole, the number of these cells goes up and their production of Th17 increases very significantly. Why is this at all important? Well, there's been an association of high salt intake in terms of fast food diets and propensity for development of de novo autoimmune conditions. Now, we don't know whether fast food influences MS, but these observations suggest that maybe a high salt intake fast food based diet could underlie why we're seeing an increased prevalence of multiple sclerosis, and certainly might be yet another environmental risk factor associated with MS. So very provocative work, very new work, just presented last week at the Academy, but suggesting that maybe the dietary intake of salt could have an impact on the immune system and thereby have an impact on MS. Now, as Dr. Fox mentioned earlier, there is also an impact on another type of T cell called the T regulatory cell that has regulatory functions and controls the effects of these other cells. So there's a lot of interest in Treg cells. Treg cells are decreased in MS patients, and it's possible that we could potentially use medications to induce Treg cells that could control some of this pro-inflammatory effects of either the Th17 cells or the Th1 cells. All right, now for the next 3 hours and 45 minutes, I'm going to go through this slide in great detail. Again, you know, the point of this ever-increasing complexity is to indicate that there are multiple cell types, multiple surface markers of cells, multiple biomarkers that may have great significance for MS therapies. And I'm just going to show you a couple examples here. Here are adhesion molecule biomarkers illustrated on the same slide that are involved, of course you can't see it now, involved in blocking the egress of lymphocytes from the blood into the brain. And just to show you these again illustrated, they're all here: ICAM, VCAM, VLA4, LFA1. Antigen processing and presenting biomarkers are also present. CD40, as illustrated again in the middle here, where those lymphocytes get reactivated in the central nervous system and stimulate a pro-inflammatory event. So there are just a couple examples of biomarkers that we can think about, and there are many other MS-associated biomarkers. And again, this is in your handout, and we're certainly able to provide these references to you as well. But there are biomarkers for blood-brain barrier disruption, for demyelination, for other markers of gliosis and central nervous system injury, and possibly for central nervous system repair as well. Now, in terms of clinical biomarkers, there are several types of biomarkers. We can look at biomarkers associated with MS risk, such as family history, vitamin D, staging the extent of the disease. MRI can be useful to some extent. Prognostic markers, such as MRI, and markers that can differentiate different types of demyelinating disease. So neuromyelitis optica can be distinguished from multiple sclerosis based on this NMO-IgG antibody. We can also predict to some extent how a patient will respond to a particular treatment, and a very important biomarker is that for JC virus seropositivity, which will stratify risk for patients in terms of development of PML when treated with natalizumab. And here, JC virus seropositivity has some predictive value about who might get PML, but really JC virus negativity has the best negative predictive value about who won't get PML. Very, very useful in natalizumab-treated patients. All right, just a couple examples of biomarkers that have been recently studied. Here, interleukin-22, one of those molecules that lymphocytes use to communicate with each other, has been shown to be increased in MS relapses. It's upregulated during that period of time, and is part of our understanding of immune regulation in MS. CSF IL-1B has also been correlated with inflammatory events, in particular with cortical lesions in early MS. And what you can see here is the number of lesions is associated with having interleukin 1B expressed within the central nervous system. These are just two examples of biomarkers that correlate with disease activity. Now, other biomarkers have predictive value. We can look at a whole variety of clinical endpoints. These are the ones that have traditionally been used in MS clinical trials, ones that we've already spoken about. And in terms of patient-oriented endpoints, several of these are very important, especially when we're thinking in terms of symptomatic management, but also in terms of correlating our more hard or generally accepted endpoints like EDSS and MRI. We also want to know about walking problems, fatigue, pain, bladder dysfunction, vision loss, ataxia, and so on. So these are all important endpoints that are patient-oriented, and we use questionnaires to really address these. So just to give an example about how all these things come together is an example of gait impairment. And gait impairment is multifactorial. It can involve ataxia, it can involve muscle weakness, sensory loss, spasticity, fatigue, and of course pain. Now, I have just a couple last slides before we go on to our next presentation. This is, I think, an important slide. It helps put things into perspective. There is an important caveat of this type of information when it's presented. We are doing cross-trial comparisons here. And the reductions, for example, at the top in terms of annualized relapse rate, one might want to say that a number such as 58% is a lot better than a number such as 23%. But there's a danger there in concluding that because these numbers are higher or better, that the product is more efficacious. And that's because the effect in a placebo group may be very different across different trials, and therefore the relative reductions relative to placebo may be quite variant. So you have to take that into account when looking at this. But this is really intended to provide you some information, cross-trial comparison, with all the attendant caveats about how the various oral therapies that we now have developed in MS perform relative to their placebos. So we've got a lot of challenges with respect to treatment. We don't really have anything that completely arrests the MS disease process. We don't have drugs that really are proven to slow progressive neurodegeneration, although some of the recent compounds are provocative. And wouldn't it be great if we could incorporate biomarkers for neurodegeneration back into studies with these newer products? For example, if we really believe that dimethyl fumarate has an impact on oxidative stress, wouldn't it be great to look at one of the molecules which is supposed to be induced by dimethyl fumarate in vivo? And we could potentially look at glutathione in vivo, do glutathione mapping using high-field MR spectroscopy and determine whether treatment with dimethyl fumarate actually induced this antioxidative compound. It's just one of the things that we could think about in terms of biomarkers and then relate that to the clinical efficacy of the drug. We haven't delved deeply into disease-free status, but this is a very provocative measure that was indicated on this last slide at the bottom here. And disease-free status really refers to the group of patients who've had no relapses, no disability, no evidence of new MRI lesions. In other words, the group of patients that both clinically and radiographically look like they're in remission. And as you can see, each of these drugs is capable of doing that for our patients, some perhaps to a greater extent than others. But this is, I think, the direction ultimately where we want to go. We want to provide patients a sustained remission from active disease. And you can see for these oral compounds, there are varying degrees of efficacy, although they all do it to some extent. Ultimately, we're going to want to optimize therapy. And one of, I think, the key things that is missing from our armamentarium at this point is really knowing how to sequence and stage therapy. What we've got are all these trials that look at each drug versus placebo or each drug versus another drug. But what we don't have is a trial which is an MS treatment algorithm trial, where you start on drug number 1 to see how you do based on either MRI or clinical evidence of disease activity. You go on to drug number 2. And then see how you do. And if you have more disease activity, maybe you go on to agent number 3. Maybe we incorporate with that risks associated with certain treatments. Maybe, for example, if drug number 2 is natalizumab, we incorporate the JC virus serology assay to stratify who goes on natalizumab, who goes on a different treatment. These are some of the key ideas that I think we are going to be very much challenged with in the years to come, because in the absence of data, all we are left with is our interpretations, our personal interpretations of the type of information I went through with you already. And regrettably, what we don't have are biomarkers that really help us know which is going to be the optimal patient for which medication. So a lot of work needs to be done. Combination therapy looks to be quite interesting. We went through a lull where we weren't using combination therapy at all, but I think this is something that we have to reconsider at this point. But there are probably going to be challenges with respect to drug costs in that regard. So in conclusion, there are many biomarkers with different mechanisms in MS, but none have been determined to be really good surrogates for our clinical outcomes, and our clinical and radiographic measures are really the best measures that we have. Some biomarkers can be useful in terms of monitoring specific mechanisms and to help direct therapies. And I would say that the JC virus serology test is really the best one that we have there. We've got multiple mechanisms and risk factors, and this really complicates our disease management. And what we desperately need is an algorithm-based approach to MS that can really help us sort out what to do with our patients as they sequence or cycle through treatments.